was the only unresolved issue that was left on the table. And, you know, it's great that we have the weekend to I guess, bring it up again later. But the fact of the matter is, we went back there to resolve something, not to just hang out.
I thought that we all had agreed to something. I thought it was, you can talk about them leaving, you can talk about the other stuff. If that's not the case, then we're just going to have to address it as it comes. And then make our record.
That's where I thought we had kind of left it, because I specifically recall saying, well, you know, our issue is that, I think I used the metaphor, the horse has already left the barn on the things you were concerned about. And they said, well, we'll leave that alone for now, and but not going to strike anything, and we're going to still argue it in closing. But now all of a sudden, halfway through our case, we can't. We're precluded from going further. Well, we still have witnesses we would like to talk to them about.
Okay, well, let's make our record. You know, I can only go on things. You have a 403 issue going on here, we can deal with it.
Okay, thank you, Judge.
It eventually becomes cumulative. Is it relevant? Is the probative value, is it outweighed by the prejudicial effect?
Well, Judge, and I would just remind you that if this was one instance, yeah, I would concede that point.
Well, where we have 14 counts.
And you know, so all of these witnesses are like brand new as to an issue. So it's not cumulative as to these cases, to the counts they're testifying about.
Judge, I thought that's why the court took the time out away from the jury, and the jury had to be waiting in the jury room while we resolve these issues. What's the point of taking time to resolve these issues if you can come back after the weekend and say, well,
okay.
I didn't agree to anything.
I understand what you're saying. Okay? It wasn't the reason I took the time out. Okay? So that aside, you know, we're just going to have to play it through, I guess. So I'll note everybody's objections, their comments. I'll let everybody prop the record, but I want to get this jury going.
All right.
We would have ask for a standing objection to any of these topics being broached, so that I'm not drawing extra attention to it already by the constant objections.
Well, I think everybody understands what the issue is, and I think the Court of Appeals is not the foundation to deal with it. We're just going to have to play it by ear. And let's see where the questions go.
Yes, sir.
Yeah.
All rise.
You may be seated. Good morning, ladies and gentlemen of the jury. Just so the parties know, Mr. Petticus was gone this morning because of a family issue. I had to look the jurors in, so I actually have to talk to a couple of them. Good mornings, that was about it. I didn't talk about the case, did I, guys? No. With that, Mr. Zion, call your next witness.
Thank you, Your Honor. The state of Ohio calls Jake Deemer to the stand.
Y'all have a good weekend? Y'all look pretty rested. You. That's different. Our son. Yeah, well, Sunday night, I think I slept 10.5 hours. So when I got up, it was late afternoon. It's a good thing.
Please remain standing and raise your right hand when addressed.
Okay. You solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
Yes.
You're going to make yourself comfortable. You can lower your mask if you like. Okay, you got that aerial mic there in front of you. I need you to state your name for the record and spell it so my recorder can get your diction.
My name is Jacob Deemer. It's Jacob, last name Deemer.
Okay, can you guys hear him? Okay? You want a little volume? Little volume, okay?
Yes.
You can yell, it's okay.
Yes.
This is on.
Thank you, sir. Can you please tell us, where did you grow up?
I grew up around Pittsburgh, Pennsylvania.
And what college did you go to?
I went to Capital University from 2012 to 2016.
What did you study at Capital University?
I got my bachelor's in science degree in nursing.
All right. Tell us about your training that you went through at Capital University to do what you to get that degree.
Yeah, so Capital, obviously you have your coursework. You study basic intro level stuff to nursing and healthcare, but then also you couple that with some clinical where you sort of have a residency, if you will, at various hospitals around Columbus. Respectfully, I enjoyed my time at Capital. However, you really learn a lot on how to do your job on the job. So Capital was more of getting your feet wet.
Well, tell us about your clinical experience while studying. What, if any, hospitals locally did you study at while at Capital?
Yes, I did. My first clinical was at Mount Carmel East. I rotated through Riverside. I did OB, maternity infant at Riverside. I did community health, and then I also did a preceptorship experience, which is where they pair you and shadow you with a nurse. And I did that at Grant in their trauma bay.
All right. At some point, did you wish to do a preceptorship in the ICU while studying to be a nurse?
Yes.
And were you able to do that while studying to be a nurse?
No.
Okay. Did you want to work eventually in the ICU?
Yes.
All right. So what year did you graduate nursing school? The Capital with a degree in, it's an MS, Master's of Science?
No, so the first one's a Bachelor's of Science in Nursing. It's a 4-year degree, so I graduated in 2016.
All right. And did you thereafter take a test, a board, to become a nurse licensed in practice in the state of Ohio?
Yes, it's a NCLEX RN.
Say that for the record reporter, spell that out.
NCLEX, NCLEX-RN. It's our licensure examination.
And when did you take that in 2016?
A couple months after I graduated, so maybe, I graduated in May, so maybe July, roughly.
Did you thereafter get a job somewhere?
I did.
Where did you get the job?
Mount Carmel West.
And what position did you apply for, and what position did you get?
I became an ICU registered nurse at Mount Carmel West.
Did you apply for, or were you assigned a particular shift as an ICU registered nurse at Mount Carmel West?
So I worked the night shift, sort of by choice, but also by need. On the night shift, there's tend to be less resources in the terms of people in-house, so it's a little bit slower for new nurses, so you can kind of focus on your patients, but then also respectfully, there's less distractions, and you get paid a little bit more, and I wanted to make more money.
Makes sense, brand new. So this is your first job as a nurse, and when month you took your test, and you estimate July of 16. When are you starting your job at Mount Carmel?
Maybe September, shortly thereafter. It was contingent, my job beginning was contingent on me passing that board examination. So the onboarding process started shortly after I passed. The exact month escapes me anymore.
Okay. Tell the jury about your onboarding process with Mount Carmel. Was there an orientation period? Did you work other shifts, etc.?
So yeah, so there was technically an orientation period. It consisted of shadowing other nurses. Basically, it was should have been in theory, a methodical way to introduce concepts and how to do your job to a new nurse, specifically any nurse, but also a new grad orientation. You would primarily follow around a nurse on the day shift and then on the night shift. For me personally, I spent the majority of that orientation on the night shift, although I did do some days. But it's important, I guess, that Mount Carmel recognized the preceptorship experience as everybody being one nurse. So since I really had a minimal understanding of having never worked in a hospital, they would pair me with an experienced nurse, and I was basically tethered to that nurse. So anything that I did, they would sign off on, or anything that she did or he did, I would learn from that. So although 2 licensed RNs, we were considered one entity for the patient.
You said in theory it should have been a methodical introduction as to everything you would need to know. Did you find that to be what actually occurred during your orientation period?
No.
Explain that, please.
So there's a couple things. The first is there's always a nursing shortage. However, I was actually approached, I believe it was a 10 to 12 week orientation. I was approached, I believe, after week 8 by my manager, and the manager basically asked me to come off orientation early, and I expressed some concern about that, but she said that she would give me easier assignments, one patient, but basically my orientation was cut short to help staffing issues.
All right.
And being that Mount Carmel West is a mixed ICU, meaning that you can see medical patients, surgical patients, trauma patients, etc., it's not possible to see every type of patient in 8 or even 10 weeks. So there was something left to be desired for the orientation process.
So talk about how you felt experience-wise when you started. So if you started in September of 16, you passed your test and you're doing this orientation. Are we now into October, November, and you're on your own, basically?
Yeah.
All right. Talk about how comfortable you felt with the level of experience and training you had when you first started in the ICU on your own after 8 weeks of this orientation.
Yeah, I think it's relative. If there was a patient who had orders to leave the floor, I was comfortable with that. Basically very stable patients I was comfortable with, but there always was a little bit of apprehension. But I knew that I could go to my coworkers and ask for help. But I told them in advance in the huddles that I might be asking a lot of questions.
Okay. Talk about your understanding of the level of experience of your coworkers in general in the ICU back when you started.
So the charge nurses tended to be more experienced. Several come to mind that had 10, 15 plus years of experience. I would say most of the people were 5 years or less were working on that unit, but there were nurses that had tons of years of experience, but there were far more newer nurses than there were, 30-year veterans or something like that.
All right. And when you say newer, could you estimate, in your mind, your understanding, when you say newer, is that 5 years or less, or even less than that?
For me, I felt comfortable, really comfortable, and felt like I could teach other people at about 1.5 years. So I would say, when I say newer, I would say like between 1 and 3 years of experience.
All right. Did you have aspirations to continue in your education and seek a higher level of nursing certification when you started on this journey, started working at the ICU in 2016?
Yes.
What is that aspiration that you had?
To seek a career in nurse anesthesia. It's called a Certified Registered Nurse Anesthetist, or a CRNA. That was my goal from a very young age.
And would that require you to gain experience and then go and get more schooling, more education?
Yes.
All right. So this is something you had in mind when you started in 2016?
Correct.
All right. So tell us about, once you were past orientation, did you work exclusively on the night shift then?
Yes.
And tell us about what doctors you would work with on the night shift in the ICU at Mount Carmel West.
There were two doctors, Dr. Hagris and Dr. Husel.
All right. And did they seem to split the ICU their time between the two of them evenly?
Yes.
All right. In your experience, did you find that you were working more with one of those two particular doctors?
It's hard to say. I would say maybe 60-40, but it depends. What I can say is I never put my work shift to line up with any of the doctors. It was organic when I worked. So I worked with them. Some days I would work with Dr. Husel 3 in a row, and then I wouldn't see him for 2 weeks. Other days I'd work with Dr. Hagris, so I can't say. Maybe 50-50. Okay.
Do you recall at a previous hearing saying that you, for whatever reasons, like organic you've just described, you would tend to, in your mind, you had worked more with Dr. Husel?
Yeah, I remember saying that. I guess like if you're asking me to put a percentage on it, I can't. So, I mean, maybe shortly when I was asked that question, I don't know. I don't know. I would say that Dr. Husel seemed to work more shifts than Dr. Hagris. That's what I can say.
Okay. On a personal and or professional level, did you have a closer relationship with one of those two doctors?
Yes.
And which two of those doctors did you have a closer professional and personal relationship with?
Both, but number one was Dr. Husel.
And can you describe what, if anything, in your mind, attracted you to, in a professional sense, Dr. Husel?
Yes. His first and foremost, when I was orienting on the day shift, it was common knowledge, or at least it appeared to be common knowledge, that there was a doctor on the night shift who was very good, knew his stuff, highly educated, highly trained, and he would be a very good resource to learn, especially being new. Second, he was in anesthesia, and I had aspirations to go to anesthesia school, so I thought it would be, so here's a highly accomplished professional with training at the Cleveland Clinic who is doing the thing that I want to be doing or something similar, and he's apparently very good. I should probably figure out why he thinks the way he thinks and learn how he does the things that he does, because it's led him to a great deal of success. So I like to copy people who have walked the path before me, because usually they're on to something.
Tell us about your understanding of the reputation of the Cleveland Clinic. You mentioned that by name, that he was trained as an anesthesiologist at the Cleveland Clinic.
Yeah, I can speak to it. I've actually trained there as well. It has a reputation for being a place where people who are very sick go. There aren't many hospital systems around here that are better than the Cleveland Clinic. In fact, people come from around the world to go there. So that's a pretty highly prestigious institution.
And this was something known to you and to others regarding Dr. Husel's background?
You mean where he trained? Mm-hmm. Yeah.
Okay. Were you aware of any awards that he had won previous to your employment?
I'm not sure previous to the employment, but I did know, and I came to know at some point, that he was voted, I believe it was Mount Carmel Physician of the Year.
And are you aware if this was something that was, that award was nurse-driven? This was something that the nurses would vote on to?
No.
Okay.
I didn't know how they came to that.
All right. All right, well, tell us about the first time you remember having contact with Dr. Husel, and what was that? What was it? Just to lay a foundation for your relationship.
I'm not sure if I remember the first time I met him.
All right. What's the first interaction that you do recall?
Yeah, I remember he came up to me. It was a slower night for me, being new, and he pulled me into my patient's room, and he said, "Hey, this patient's on a ventilator. If I want to control ventilation or CO2, what numbers would I manipulate on this ventilator?" And I missed the question. I had no idea, to be honest. And he educated me. And I, although respected, I always researched for myself. So I had gone home later that night. I bought books to study on my own time. And I basically read about the things that he said, and it turned out to be true. So I just remember being educated about something.
But on his own, he came to you, took you aside, and took this time out of his schedule to help you.
Yeah, he did that with everybody.
All right. Would you ever talk to him about anything that wasn't work-related? Did you feel you had a relationship with him otherwise?
Yes.
Tell us about that.
Him and I have mutual interest in fitness, so we would talk about lifting. We would talk about basketball. We would talk about the game the night before. We would talk about the Twilight Zone episodes. He was very approachable, but it was in a, well, he was very approachable.
All right. Did you two ever have socialize outside of work?
To my knowledge, no. We had talked a couple times, but those things were just talk.
Did you consider him a mentor?
Yes.
Did you describe his professional relationship being around him as more of an extended sort of preceptorship?
100%, yes.
And in fact, a preceptorship that...
Direction, leading.
Rephrase.
How would you describe this extended sort of... did you receive this type of extended sort of preceptorship in college?
I'm not sure I understand.
Did you receive this type of training that he was giving you in college?
No. In my experience, there's not many nurses who, ICU is such a niche job that you don't encounter many nurses that have ICU knowledge, so I wasn't likely to encounter any of these concepts in a trauma bay at Grant.
Okay. So what you're learning about the ICU and how it functioned is from your professional relationship, this mentorship with Dr. Husel.
Not mutually exclusive, but yes, he is part of that. There's other nurses, other doctors, even respiratory therapists. They're all helping to sort of educate me. But when it comes to educating, he was the only guy who would come up to you and be like, hey, if you have 5 minutes, name anything in this ICU and let's talk about it. I've seen him do that with respiratory therapists as well, and techs, people going to nursing school.
Did Dr. Husel ever write you a letter of recommendation?
Yes,
What did he write you a letter of recommendation for?
an application to get into anesthesia school.
All right.
I also received a letter from Dr. Hagris as well.
Okay. All right, let's talk about your training and knowledge at the time about
Yeah.
narcotics and benzodiazepines. Let's start about the extent of the training you received at Capital University, either in the classroom and or on the job regarding narcotics and benzodiazepines.
Very little. At Capital, we took one pharmacology class. I believe it ran for the duration of my junior year. Excuse me. And what it encompassed was basically talking about the group of medications and not actually discussing specifics about medications. So she would say narcotics, drugs you may encounter, could be Dilaudid, morphine, fentanyl, but we never actually broke down the differences between the two. It was like you basically covered one group of medications twice a week, and then you moved on to the next one. So very little to answer your question.
Did you recall at a previous hearing describing it as almost none?
Yeah, I would say that's pretty much almost none.
Okay. So walking into the ICU in the fall of 2016, you have almost none as far as training in the use and application of narcotic pain medication and benzodiazepines.
I had given some, I mean, in my clinicals, but if you're at, I was unable to break it down on a pharmacological level as to how they worked.
Are you familiar with package inserts for these drugs?
I am.
And can you tell the ladies and gentlemen of the jury what a package insert is for these drugs in general?
Yeah, in general, a package insert is basically a piece of paper or a document that's included inside of the container that the meds are shipped in. It carries with it details and information about the drug. For example, Tylenol would have a package insert, so when the hospital orders a bulk order of Tylenol, there's a package insert and it would say important considerations to consider. It would list anything that you need to be aware of, and it would list a myriad of side effects and things like that. So it was, if you didn't know anything about the drug, you could read that and kind of get a sense of what it was for and how it worked.
Does fentanyl have a package insert?
It should, yes.
And were you aware of it back then in 2016, 17, 18, those years? Had you read the package insert for fentanyl?
No.
Okay. What about benzodiazepines such as midazolam and or Ativan? Do they have package inserts?
Yes.
And were you familiar or had you read the package inserts for those benzodiazepines, midazolam and or Ativan?
I'm not sure.
Okay. Was your knowledge back then that they would have recommended dosages? Like you said, for acetaminophen, I think you said it had like a recommended dosage?
I don't think I said that.
Oh, okay, I'm sorry. Well, were you aware of whether, in general, package inserts have a recommended dosage for their use?
I think it depends, but back then I would not have known that.
Okay. Talk about the training you received regarding policies and procedures of Mount Carmel during your orientation and or afterwards.
So similar to my main orientation, it was incumbent upon the elder nurse who was training you to basically teach you where to go and where to find the policies. So it really depended on if the nurse you were learning from even knew where to find them. They were notoriously difficult to find. So there's the internet. Mount Carmel has an intranet, so it's their own like in-house internet. And you had to click, in my opinion, it was difficult to locate those policies and procedures. So they were not readily a part of my orientation process. And to be quite honest, I'm not sure. It would have taken a considerable amount of focus to figure out where to find them.
Were you ever made aware of any policies or procedures or order sets that were in the Mount Carmel policies and procedures for palliative extubations in 2016 to 2018?
I'm not sure.
At that time, were you aware of Mount Carmel's medication administration and self-administration guidelines procedures?
Is that the same thing as Lexicomp?
Lexicomp is part of that, yeah.
I was aware of Lexicomp.
Were you aware whether or not doses could be adjusted outside of those guidelines?
Yeah.
Are you aware of what needed to be done if those dosages were administered outside of the guidelines in that policy and procedure?
Can you be more specific?
Well, under what circumstances, if you're aware, could dosages of medicines be administered outside the guidelines for fentanyl?
Objection, foundation.
I'll permit the question.
At the time,
At the time.
I believe so, yes. And some of those things that would require them to be adjusted could be opioid tolerance, weight, age, any sort of factor that makes us different. I believe one of them is palliative care.
Were you aware of whether or not you needed to go outside of those guidelines? You would need literature, some sort of either learned article and or...
Objection.
I'll let him finish the question.
Sure.
Were you aware that one of those guideline deviation requirements was literature that needed to be cited to go outside those guidelines?
Aside from being leading, it's misleading too.
Okay, well, we're not doing closing argument. Let's relax.
I understand. Argumentative, and it does not apply to palliative withdrawal situations.
Okay. As the leading, sustained. Rephrase.
Were you aware of what, if any, awareness did you have of literature requirements to go outside the guidelines?
I wasn't aware that I have to provide, I wouldn't even know who to give an article to. No, I was unaware.
What, if anything, were you aware of regarding special approval absent that literature from someone higher up in the chain of command?
Objection, asked and answered.
I don't think so. I'll permit it. Do you understand the question?
A little bit, no.
Absent literature
Okay.
that would support going outside the guidelines, were you aware of any requirement to get special approval from people higher up in your chain of command?
I would say that the people in my chain of command were involved in those practices. So I didn't seek any higher level charge nurse approval or something like that because the charge nurses are the ones who trained me and most are involved in this. So, no.
So you weren't aware of that special, of absent literature having to go up the chain of command?
Okay, overruled.
Correct.
He's just clearing up an issue. Go ahead.
Yeah.
All right. So to summarize and for transition, you received almost no training in...
Objection.
Well, I'll let him finish the question there. Go ahead.
For transition and for summary, as we go into the next topic, you received almost no training in college about the use of opioids and benzodiazepines beyond what you described. Is that correct?
Yeah.
You received no training about the use of benzodiazepines and narcotic medication during the preceptorship, the 8-week preceptorship you had, besides what you've described as being present when they were administered.
Asked and answered.
Well, he's in transition. I'll permit it.
Yes, I mean, I've given those medications to patients, but my understanding of them was limited.
And because of the difficulties in using the intranet,
Yes.
you had almost no knowledge or training regarding Mount Carmel's policies and procedures for use of those medications.
They were difficult
Permit
to,
it. It's transitional.
they were difficult to find.
All right.
Let's transition though. We're getting,
Right.
okay.
And now we're moving on. One last question, then we're moving on to the particulars of this case, Your Honor. And you've testified at a previous hearing that almost everything you knew in your first year of practice came from Dr. Husel.
Objection. This states the evidence, and this is the
Okay.
third transitional question.
Wow. There is no count, but that's beside the point. I'll permit the question.
Ask it again, please.
Almost everything you learned in your first year of practice at Mount Carmel was taught to you by Dr. Husel.
No, that wasn't the question. You previously testified to that. Is that correct?
If that's what I said, that's what I said.
Okay. So let's talk about December 5th, 2017.
Okay.
Do you recall a patient by the name of Danny Millette?
Yes.
All right. Looking back in your mind's eye, you've had a chance to review the medical records, right?
Yes.
With that in your mind and looking back also, I want your independent recollection.
Okay.
Tell us about the first time you became aware of Danny Millette at Mount Carmel in December of 2017.
I was coming to work and I was responsible to take care of him.
All right. Describe his age, his condition, what you remember about him as you got to work, and what you did next.
So it was reported to me, he was an older guy, I believe he was in his 70s roughly. He had an extensive history of peripheral vascular disease, diabetes.
I'm going to
Yes.
stop you there. What is peripheral vascular disease? Your understanding of that back in 2006?
Objection. Is the counsel asking the jury this question?
Yeah, well, let's stay over here, but I'll permit the question.
You're asking me what my understanding back in 2017 was
Of peripheral artery disease.
of peripheral vascular
Vascular
disease?
disease, yes, thank you.
It's similar to peripheral arterial disease. So basically, I would have known this at the time as well, because of underlying factors, sometimes genetics, sometimes smoking, sometimes diabetes, all of which this gentleman did. It would cause your vessels in your hands and your legs and your body, everywhere in between, to become, I'll say, rigid, less pliable, so it's not able to adapt accordingly, and it can lead to issues if you think of a pipe, and I'm trying to get water through the pipe to an area. I'm trying to get blood from my heart to my foot, for example. If there's a kink in the pipe somewhere, or the pipe is smaller, or it's occluded or clotted, you're not going to get water to the end goal. So peripheral vascular disease and peripheral arterial disease would be the equivalent of not being able to get blood to certain areas of the body. And without blood and oxygen, importantly, to those areas of the body, you can have very bad issues.
Peripheral means like the in parts of your body, right? Is that what
No.
peripheral? No?
No.
Okay.
Like it could be it could be systemic. I don't know why it's called peripheral, but there's, peripheral's relative.
Okay. Do you recall whether or not Mr. Millett had any recent amputations?
He did have an amputation of a toe,
Okay.
secondary to those things that I described: diabetes, smoking, peripheral vascular disease. But he also additionally had a procedure, I believe it was a bypass graft. So that's a little bit bigger of an issue. So when you're dealing with bypassing vessels, you're actually bypassing bigger vessels in the body to try to reestablish or maneuver around clotted or bad areas of vasculature.
Do you recall, you said you recall him being in his 70s. Do you recall what his height and weight was?
No.
Is there anything I could show you which would help refresh your recollection as to his height and weight?
Sure. Yes.
Would the medical records help you establish his
Height and weight?
height and weight?
Yeah. Yes.
It's my understanding the records are stipulated.
The records are stipulated, Your Honor.
Why don't you just ask them if the question then?
Okay. If the records indicate that he was 5 foot 8 inches and 140 pounds, does that help? Does that sound about right in your mind's eye looking back on it?
Yes.
Okay. And he has had this toe amputated. He's had a vascular bypass done on his leg. Were all of these things been made known to you as you come into work that day?
Yes.
Okay. And you're working the night shift in the ICU, right?
Yes.
All right. So looking back in your mind's eye, it's December of 2017. You walk in. We've heard about this handoff or huddle that you have with the previous care team.
Yeah, that's correct. The day shift nurse would give me report. This is the gentleman, this is why we're here and how we got to this point and what we're doing.
Okay. And did you do that with Mr. Millett?
Yes.
All right. And so in our timeline, this is about a year into your work.
Yeah, roughly, yes.
You've been working at Mount Carmel in the night shift for about a year, maybe a little more than it.
Correct.
Okay. And do you recall who the doctor was on shift that night?
It would be Dr. Husel.
All right. So what happens? What happens next? You walk into his room, I'm assuming, at some point?
Yeah, I walked into the room.
Tell the jury about the care. What are you doing? What are you looking at?
So I'm looking at everything. Obviously, I get in report that this gentleman is very sick. So he had this procedure, and he's back with complications secondary to some procedures. He has septic shock. So septic shock is a pretty bad bloodstream infection that can lead to some very bad outcomes. So I get in report that he's on vasopressors, Levophed, or another name is norepinephrine. And to me, that's significant right there. And I believe he's intubated at the time as well. So in my mind, at least the way that I process information, I hear about septic shock, which is potentially fatal. I hear about him requiring ventilatory support, so his lungs have failed. His kidney function has failed, as evidenced by his lab work. He's requiring adrenaline, basically. So like I always say that when I think of vasopressors, that is the stuff that pumps through a mother's veins when she pulls cars off kids. That's adrenaline. This is noradrenaline. We're giving that in an IV. And I believe he had needed CPR at some point as well. So he's very, very sick. So yes, I enter the room knowing all of this. I check my drips, I check the patient, I see where we're at.
What happens next?
At some point throughout the stay, after my initial assessment, I made it part of my regular practice that when I have a super sick patient like that, I'm trying to check something every 10 minutes, every 15 minutes. I'm at least around the room, if not in the room at all times. So for this gentleman in particular, something that stands out is upon doing my assessment, part of it is to check pulses in the extremities. You check them in the neck, in the groin, in the feet, in the hands, etc. He lost pulses in his left limb, in his left lower limb. So that is significant to me because 1 minute he's, I'm gonna say relatively fine given all those things I described, and then 1 minute later we have this drastic change to where quite literally, going back to my example of trying to get the water somewhere or the blood somewhere, his leg will begin to rot now. So it's going without oxygen, the whole leg. So my initial reaction is to call the doctor. So I called Dr. Husel. Dr. Husel comes to the bedside. We assess the leg. We both cannot appreciate the presence of pulses. So we put what's called a bear hugger, which is a glorified name for a warmer, on the patient's leg to try to bring warmth, which brings heat, which brings blood to the area. And I believe a vascular surgery consult was placed. So this is indicating to me that while we were sick when I came in, we are beginning to get worse. We are starting to lose perfusion to limbs of the body.
All right, so you say you checked the left lower limb, so is the bottom part of his leg here?
Yeah, yes. The knee and below, yeah.
All right, so are you just doing it with your fingers, you do it with the stethoscope?
You could do it, so the way that I do it, I start by trying to touch them. I try to palpate them. Failure to do that, usually I like to think I'm pretty good at that. I was unable to. Sometimes the patient is swollen and you can't. So then my next intervention was to grab a Doppler. So a Doppler is basically like an ultrasound that you could listen to a baby's heartbeat with. You basically put gel and you just move this little dial around until you hear something.
How long is his left lower leg?
Yes.
And you can't hear anything.
Which is pretty much indicative that perfusion has been compromised.
Okay.
Okay, hold on. When you let him get his question out, a couple
sorry.
times you want to get out there, get that answer out there, we'll get to it.
Yes,
But this poor lady's taking it down here, and we don't want her fingers to go up in smoke, so.
Yes, sir.
Mr. Zion?
Sorry.
So you said Dr. Husel came in, confirmed what you found. The vascular consult was done. What happens next?
It gets pretty vague from there, to be honest.
All right. Does his situation improve in your mind's eye as you look back on this, or does his situation continue to deteriorate as you look back on this?
As I look back, in my opinion, it continues to deteriorate. When you have a drastic change like that, it's important to let family know. It's important to keep them in the loop so they can make informed decisions about the goals of care. And I believe at some point shortly after that, the family was updated with what was going on.
Okay. What about his condition? As you look back, having reviewed the medical records, he's intubated, you described his medical condition. What about his awareness? Do you recall if he was awake, if he's talking to people? Because you can be awake and ventilated, right?
You can.
Yeah. Was he awake?
No.
What about his level of consciousness that you recall, and based on the medical records?
He was fairly, I'm trying to use the right word. Let me think. He was out of it. That's what I'm going to say.
Okay. So you can't talk to him about what he wants next, right?
Correct.
So you talk to the family.
Yes. The primary decision maker, which is usually always family.
Okay. So did you participate in this conversation with the family?
Yes.
All right. Was Dr. Husel present, and did Dr. Husel, in your memory, participate in this discussion?
Always. It was customary in my practice. Anytime that I was updating family with something significant, the doctor had to be present at the bedside.
Okay. Did you bring the family into bedside, or did you meet with them in a family room?
That I don't remember.
Okay.
In my practice, usually at the bedside, but I can't say specifically for this.
All right. What, if anything, do you remember about what you said to the family regarding Mr. Millett's condition and prognosis?
Yeah, I basically told them the same thing I told you. I would have said, we're having changes in his care here. We're giving this medication called adrenaline. It had not been explained that way to them before. I told them about this newfound change in his status, what we were trying to do to remedy that, and then I think we referenced some lab work. And I was a part of that, like pulling up on the computer and things of that nature.
Are you aware that in the medical records, the family had already agreed that afternoon to what's called a DNR-CCA?
Yeah, correct.
And what, in your mind, in your understanding back in 2017, DNR-CCA meant?
Yeah, so DNR-CCA, you have a full code, which is do all heroic measures, CPR, life support, intubation, all those things. Then you have a DNR-CCA, which means do everything that you can up until the point that the patient dies. And then if they do die, do nothing. Let that be the end. And then you have a DNR-CC. DNR-CC would be removal of heroic measures and allow sort of a natural passing without artificial means of life support. So he was a DNR-CCA, meaning that if he would lose pulses and die again, we would not implement life-saving interventions from that point to bring him back.
So what happened after this family meeting with you, Dr. Husel, and the representatives from the family there?
They agreed to change the code status to DNR-CC. So it was told to us, it was told to me that, passing naturally, pain-free, comfortable with the family at the bedside and not having tubes shoved in every body orifice was what the family wanted.
Okay. Do you recall what time of the shift this was for you that this decision was made?
I don't.
But working 7 to 7, this would have been in the evening hours or morning hours?
That would be my normal hours, so that I don't really think of it like that.
Okay.
It's a 24-hour job.
Sure. But this is happening during the night shift at some point.
The change in care is correct.
All right. So what happens next after the family agrees to a DNR-CC?
Well, we talk a little bit about what that process is going to be like. It is discussed that, we're going to give pain medication. We're going to give medication to help promote comfort and only comfort. And we are going to remove and turn off these things that were keeping the patient alive. We discussed how It could be, it was impossible to determine how long, because most of the time people ask how long until, and it's, we say, we don't know, we're turning off these medications, but we're going to give him pain medication to help make sure he's comfortable. We actually discussed, like, all of the stuff that we were going to do.
Did you talk to them about agonal breathing and or the secretions that could build in his throat and what that meant as far as his discomfort and or anxiety and or pain?
Yes. Particularly the ones that I focused on was the rattling, secretions, vomiting, turning different colors. Sometimes you say agonal breathing, I think paradoxical breathing, meaning that when we breathe, your belly and your lungs tend to expand. Well, there's chances that one can go out and the other sucks in, so they work against each other. I've seen it, and it appears to be very uncomfortable.
So you prepare them for that. What did your training and experience tell you in 2017 about if that was actually painful or uncomfortable for the patient going through those things?
I don't think, personally, respectfully, I don't think any amount of education or training could prepare you for seeing something like that. So all training kind of goes out the window when you see somebody kind of like that. So I don't really have, I'm not sure what you're asking me.
Did you have any training regarding whether or not agonal breathing and or the secretions in the throat, it's also been called the death rattle, I think they're called that, whether or not that was actually, disturbing for the family to watch, and you, apparently.
Yes.
What about, did you have any training regarding whether or not that was actually painful for the patient and or anxiety-inducing for the patient?
Specifically, secretions in the throat, and you say agonal breathing.
Agonal, paradoxal breathing, guppy breathing, all that?
I'm not sure if I ever read anything that said they were or were not painful.
Okay. Did you tell them the doses of pain medication? Did you get that specific? And the types? You said pain medication. Did you tell them the type of things you were going to get?
No, we didn't tell them the specific name of the pain meds that we were going to use. We just talked about that we're going to use a sedative and pain medication to promote comfort. And we talked about, we never discussed like, hey, we're going to give this much or something like that. But we said that we were going to give him an appropriate amount to make him comfortable so he could pass naturally with dignity.
Okay. As part of your review of Mr. Millet's chart and part
Yeah.
of your care earlier that evening, had you reviewed the previous pain medications and or benzodiazepines that he had received through the course of his hospital stay?
I knew that this gentleman, because in Mount Carmel system, you have, I'm trying to think what it's called. You would have had access to the previous hospital stay that he had when he had the surgery. And I knew that he got pain medication during then, when he was shortly discharged. But I don't remember what I read about his pain medication up until that point. I can't remember.
All right, you're talking about his previous, when he had his toe amputated and the vascular bypass. That was a previous hospital stay.
It was, and you have access to those records as well.
Right.
And I would attempt to make it a point to read a little bit about that, only because that's why we're back again.
Okay. So he had not, during this particular hospital stay, had that pain medication, but in the from
Periphery.
December 5th, near that date, that had all happened to him, and then he went and came back. Is that what you're saying?
I believe so.
Okay. And you would have reviewed that?
Yeah. I would have particularly looked at like the OR records because of my interest in anesthesia, but also like, if somebody is presenting back for an issue, you probably should go look at what the start to that issue was.
Okay. For this particular hospital stay, which, if the records say began on December 5th and ended on December 5th, had you had a chance to look at the medical records for that day he was in the hospital when he had come back?
I'm not sure. Wait, are you talking about the ones previous to that?
No, I'm talking about...
Oh, that day?
That day, because he was just there for a day, right?
Yeah, I'm not sure, only because he was pretty busy. I I was doing something at least every 10 to 15 minutes, so I'm not sure. Can't answer that.
All right. Were you aware that he had only come to the ER on Tylenol?
Yes.
Okay. And that the only other pain medication that had been ordered for him was 2 milligrams of hydromorphine and 1 milligram of midazolam at 2139. Does that sound right?
Yes.
Oh, you know what? I don't know.
It-
I don't know if that's right, actually.
Yeah, can we
notes.
look? Is there any way you can bring it up?
Yeah.
And we could just,
Let's
get it
talk
down?
about Danny Millet's, if we may. Is that me? While I'm looking that up, did you assess his RAS score?
yes.
What do you recall about his RAS score? And just for the jury to remind them, what is RAS and how is it evaluated?
It's called a Richmond agitation score, maybe sedation scale or something like that. It's a measure of, it's one of the ways to measure somebody's demeanor. Yeah, and seeing as though he was kind of out of it, his RAS score that I scored him at was, I believe it was a -4 is what I gave him.
So if 1 or 0 is conscious and alert, and if you go to the positive, that's when people are getting angry and agitated,
Yes,
and then it goes backwards to -5,
I believe so, yes.
completely comatose, you rated him at a -4?
I think so, yes.
I apologize about the earlier medications.
Okay.
Were you aware that the only previous pain medications he had received during that, I mean, he was just there for the day, but he came in on Tylenol?
Yeah,
Okay. So, looking back in your mind and based on your review of the medical records, what was what, if any, order was given to you by Dr. Husel regarding pain medications to be given to Mr. Millett for purposes of this palliative extubation?
yeah, I received a verbal order for fentanyl and Versed, and I believe there was a Dilaudid attached to that as well.
All right.
But I received that verbally from Dr. Husel.
What amount did you verbally receive an order for the fentanyl?
1,000 micrograms.
What amount did you receive a verbal order for the midazolam?
I know I looked at it. I don't want to say the incorrect number.
Sure.
Is it?
Showing you what I marked for identification purposes. And Judge, instead of going into since they're all coming in together, I'm just going to refer to these as States Exhibit 4, the medical administration records. Who's doing? This would be the medication. I was just going to show them the Mars, but that's just what I pulled out. May I approach the witness, Your Honor?
You may.
Showing you the joint exhibit for medical records of Danny Millett, page entitled Medication Administration Record.
Thank you.
And then I'm going to show you 2 pages of this.
Okay, thank you.
You could review that and look up once you've had a chance to review that.
Okay.
I'm sorry, I'm going to...
Okay, you're away from the mic. No, I'm just telling him he's away from the mic, so it might be difficult for the court reporter to hear you. Could you hear him okay?
Yes.
Okay.
Okay, I think I got it.
Okay. Having refreshed your memory, it was 1,000 micrograms of fentanyl. What, if any, order did he verbally give you for midazolam?
Looks like 4
Okay. And in what method were these to be given to Mr. Millett?
through an IV.
Through an IV push or through an IV bolus? Or through an IV bag?
Push.
Okay. And describe what that means to you, your understanding of that in 2017.
Yeah, draw it up in a syringe and administer it through an IV.
Do you recall the unit dosage that fentanyl was available to you in the ICU from the Pyxis machine?
100 microgram vials, so 2 mLs, 50 micrograms each.
Okay, so how many vials did you have to get out of the fentanyl to get 1,000?
10.
And do you recall the unit dose of midazolam that was available to you in the ICU Pyxis machine?
I believe 2.
So
So it's
how
1 milligram per cc, 2 milligram vials.
So how many vials of midazolam did you have to get out?
2.
And then how did you prepare these doses to be able to give them through an IV push?
Took a needle and a syringe, I drew them up, put them into the patient.
Okay. And where would you have drawn these up?
In the room?
Was the family present when you were drawing these up?
I'm not sure. I always gave family the option to stay for that. I never told them they could leave. I would be very upfront. I'll draw them up in front of them. I'll draw them up if they don't want to see. Most of the time, in my experience, I believe family stepped out just because there is the potential when you pull an endotracheal tube or an ET tube, you can have a laryngospasm, a bronchospasm, people could vomit, they could cough, secretions could come out. It could be very distressing. So people had the option to stay if they wanted to see that. But I drew these medications up in the room.
Okay. Do you recall, you said you believe there was a hydromorphine dose also ordered, given to you verbally by Dr. Husel for this procedure?
Yes,
And do you recall the dose of hydromorphine that you were asked to give?
I believe 2 milligrams.
Okay. And was this also at the same time as the fentanyl and midazolam?
Yes.
Okay. And how was that to be given to Mr. Millett?
IV push.
All right. So, in summary, the verbal order was 1,000 mics of fentanyl, 4 milligrams of midazolam, 2 milligrams of hydromorphine.
Yes.
Is that all?
On that MAR, it looks as though there was another 50 micrograms of fentanyl as well. That I don't remember, but to my knowledge, it was 1,004 and 2.
Okay. Did you ask for clarification from Dr. Husel when he gave you this verbal order?
Yeah, in fact, I called pharmacy as well.
Okay. Why did you ask for clarification from Dr. Husel when he gave you this verbal order?
Twofold. The first being that I just wanted to know where his head was at. Although a mentor to me and established, that doesn't mean that he's beyond. Sometimes, I would not be afraid to question anybody. But I sought the clarification because I wanted to kind of get a sense of, hey, where's your head at? Why are we doing it this way? things like that, because I just wanted to get on the same wavelength as him to help my understanding.
All right. And you called pharmacy.
I did.
Now, this was a verbal order. Does that mean, how did you have to withdraw it out of the Pyxis machine on a verbal order?
I would have had to go and log in and pull the medication myself.
Would this been on override?
Yeah, I using my own independent nursing judgment, believed it to be an emergency, and I thought I was justified in overriding said medication.
Okay. And while we're on the topic, based on your training and experience in the ICU at Mount Carmel West, how common were overrides?
In my experience,
Yes.
everybody did them.
Okay. Was this standard operating procedure in the ICU at Mount Carmel West, based on your experience?
For the limited time that I was on days, yes, and when I worked night shift, yes.
Okay. But you called pharmacy.
I did.
Why did you call pharmacy?
I called Greg White, and I told Greg White that, hey, we're going to do a palliative extubation on this patient. These are the medications he wants to give. I don't believe I had ever given that level of dosing before, and I just wanted to just tell pharmacy, hey, this is what we're going to be doing, and this is the meds I'm going to be using. And then I told Greg that he could come up to the bedside and talk with us if he wanted.
What happened next?
So all I know is that Greg came onto the unit. I saw Greg present on the unit. I do not know if a conversation happened. I do not know anything after that, other than I found Husel shortly thereafter. I said, hey, are we good to go? Is this still what the goals of care are? And the answer was yes.
What happened next?
I gave the medication.
What happened next?
The patient's family was asked to be back patient's family, I don't remember if they were in the room or out of the room, I'm not sure, but patient's family spent time with the patient. Him being Dr. Husel, and I sat nearby at the nurse's station to where we could be there if family needed anything.
All right. Now, we've heard from previous people that have been through this as professionals at Mount Carmel that you disconnect or black out the monitors in the room.
Yeah, it's basically a way to it's not shutting off, it is a way to pause all of the alarms in the room so it's not distressing to the family if they're praying or something like that. So they don't get to see anything, and that's only because we want them spending those last moments with their loved one. We don't want them watching the monitor. There are nurses who didn't, you didn't have to do that. That was a courtesy that we provided because we wanted that to be about their interaction and less about, okay, oh, it's flatlined, the patient is now passed. So we were able to see those outside of the unit, or not outside of the unit, outside the room, without the family having to hear or see all of that as well.
At that nurse's station, you've got a monitor up that's showing what's going on.
Yeah, there was a number of them around the unit.
Okay. So what happens next?
The patient died.
Do you recall how quickly the patient died or how long the patient lasted?
No.
Could you estimate in your mind how long it was?
Minutes.
Okay. What happens next?
We let the family spend time with their loved one. Some of them, do more prayers. Some of them do that. What happened next is the family said their goodbyes. I went in. I pulled out the remaining tubes and drains in the patient. I washed the patient. I cleaned the patient. I tried to give the patient the care that he deserved, and then I put him in a body bag and took him to the morgue. Okay. And I believe I enlisted the help of some of my other friends, co-workers as well, to help with that, just because it's a grown gentleman.
Sure. And before we move on from Mr. Millett, did you recall reviewing the pain score charting that you received during his stay at Mount Carmel on December 5th?
Yeah, I reviewed that.
And what were the previous pain scores prior to your entry as you gave the medicine?
0, or not entered.
All right. And what pain score, if any, did you give Mr. Millett as you administered those medications?
I believe I gave him a 10,
Okay.
and that is incorrect. And that is incorrect because I used something called a CPOT score. CPOT is the observational scale that you use when a patient is unable to communicate themselves. That scale goes from a 0 to an 8, whereas any other scale usually goes from 0 to 10. So I scored that trying to indicate the maximum amount of pain, and I'm not sure why I settled on 10. That could have just been a lapse in judgment on my practice.
What did you, looking back, using the CPOT scale, if you had that in your mind, oh, CPOT only goes from 0 to 8, what would you have ranked Mr. Millett's pain at the time that you administered those pain medications?
Consistent with my charting, I would have given him an 8.
Okay, and why would you have given him an 8?
So I would have given him an 8 for a myriad of reasons. The first is what's going on with him. So he's had CPR. He has a tube in his mouth. He has, I believe, an A-line, so he had a tube in his groin or wrist. I don't remember which. He has a tube shoved in his penis. He has a tube that is in his neck. He has lactic acidosis. Lactic acidosis is something that if you go on a long run or you do an extensive workout, that pain you feel is because you restricted blood flow to your muscles, to your chest, if you were benching or something like that. He has a he has a lactic acidosis level, so that could, in my opinion, be painful. So I'm scoring it based on, and he's had a surgical procedure. I've scored that based on what is going on with him. His limb is now potentially rotting off, and I'm also anticipating a good deal of pain.
Okay, let's break that down a little bit.
Okay.
Just to revisit that, you said he had a tube shoved in his penis.
Yep.
Why did he have that?
It's a urinary catheter. When you are intubated and on life support, we like to measure urinary output because that's a good indication of how the kidneys are working. In this gentleman's case, a Foley catheter, a urinary catheter was placed. His lab levels, his creatinine is a measure of kidney function, is elevated. Urine output is low. His kidneys have failed or are in the process of failing.
But that term, quote, tube jammed into penis, that's not how you describe a Foley catheter, is it?
It depends. I mean, that was how it was put to the family.
By whom?
Dr. Husel said that.
Those are Dr. Husel's words.
Yeah, and I seconded that information.
When you charted the previous 0 or didn't chart pain at all, while he is under your care as you came on the ship, did you give him any pain medication for any of the pain you felt he was in at that point?
I don't understand the question. I'm sorry.
Well, you say that it's not just based on anticipation of pulling the tube out and letting the dying process happen. You're saying all these other things that have happened to him.
Okay.
The Foley catheter, the arterial line, the chest compressions.
Right.
And when you say surgery, this isn't from December 5th. This is from a week or two before.
Objection, leading.
Okay, I'm gonna let him clean it up. Do you understand the question?
I do.
Okay.
But in regards to the specific point about surgery, there's still surgical incisions,
Okay.
and those things tend to hurt afterward. But to that point, to your question, I don't think I gave him any pain medicine leading up to that point.
Okay. And so it wasn't just those things. You were also anticipating that this process is painful and unpleasant of dying, the process of dying.
Yes, dying in that way. You know, this is, in my opinion, I always made it a point, this is atypical from regular palliative care, in my opinion. Palliative care is somebody like a loved one who gradually declines over the course of days to weeks to whatever, right? It's more of like a plane landing, a gradual descent into death, whereas I likened what I believe I was going through and what the patient was going through to a helicopter. You know, he came in, admitted on the 5th, and died on the 5th. This wasn't a gradual decline into death. This was rapid clinical decompensation.
And he did die quickly after the tube had been pulled out and those medications.
And the vasopressors were stopped. Those tend to be they don't last very long once they're turned off or stopped.
All right. Let's move on to, Judge, it's 10:15. I'm going to transition to the next patient. Are we still good? I mean, I'm just letting you know I have a transition here, but I can keep going just fine.
Why don't we go till 10:30 and then we'll take a break?
Yes, sir. Let's go to May 28th of 2018. So that was in December of 17. So we are approximately 6+ months later.
That's correct.
All right. And so now your experience is as an ICU nurse is night shift, Mount Carmel, 1.5+ plus at this point?
That's accurate.
All right. Have you been promoted to charge nurse at this point?
No, I never wanted to be a charge nurse.
Okay. Are you precepting anybody at this point?
I don't believe so, no.
All right. So, James Allen.
Okay.
Tell us about coming into work, the first time you remember seeing James Allen.
Yeah, so James Allen, I came on to work. James Allen was placed in the CV ICU. Mount Carmel had a mixed ICU, but there was another part just across the hall that had about 6 beds maybe where you could have an ICU patient. So he was in the cardiovascular ICU, although he was there for a medical-based issue. We used that because that's where the open room was. But yeah, I would have gotten a report much similar to how I described Mr. Milletti's case. So for Mr. Allen, I got report. It had been reported to me that he was admitted. He had an ejection. So one of the things that stood out up front is in his past medical history is something called an echocardiogram. That is a way to assess how well the heart functions as a pump. It fills, it pumps, it fills, it pumps. Every time that the heart pumps, a certain amount, a certain percentage of what it's filled with comes out. Normally, usually, a normal value is 60%, 65% maybe. His was 10 to 20%. So he's a very sick patient with COPD, and other coronary artery disease, coronary artery stenosis, vascular path, like peripheral vascular disease presentation. So that's the background that I get. I learned that he is admitted because he came in for a procedure. He was in endoscopy, so they took a scope down and they placed a stent in the bile duct to remove gallbladder sludge. I believe he had that twice. There was a complication which left him in the ICU. In the ICU, he was septic from that. And he was on vasopressors and undergoing care. He actually recovered from that and was transferred off of the ICU to a different part of the hospital. I don't remember where. Where I get involved is learning that, okay, secondary to all this information, he comes back to the ICU after rapid response took care of him, after having some trouble getting in contact with certain doctors. He was decompensating and came back to the ICU in what we call AFib with RVR, which is atrial fibrillation with rapid ventricular rate, which is a body's basically fight or flight mechanism trying to keep him alive because he's beginning to go septic. He's beginning to be infected. And I'm losing track right now, but there is a chance that he lost pulses. I don't remember if he coded or not, but I know that it wouldn't surprise me if you told me he did.
Okay. If the medical records reflect that he did have a code while he was there,
Yeah.
would that confirm that that memory in your mind?
Yes.
Okay. Do you recall his age?
I believe he was in the 80s.
Yeah. Do you recall his weight and height?
He was a bigger guy, bigger than the first gentleman that we discussed. I believe he would be classified as being obese. His,
If the medical records reflect that he was 6 foot and about 188 pounds, would that be obese in your mind?
it depends. If you're using a BMI scale, it's very possible. But BMI would say that we're all obese, so.
All right. Well, if the medical records say he was 6 foot and 188 pounds, would that sound right in your memory?
Sure.
Okay. So he's a very sick gentleman. That's the report you get.
And I believe he's on vasopressors as well, and he's intubated. He, in the rapid response note that I was gotten report, he vomited, and he vomited what appeared to be blood, and the blood went into his lungs. So this is what I say, like if you've ever drank water and something's gone down the wrong pipe and you cough. Well, in this instance, blood from wherever, a GI bleed or something, gastrointestinal bleed, must have went down the wrong pipe and led him to a profound pneumonia. So that pneumonia progresses to lung destruction in the form of acute respiratory distress syndrome called ARDS or ARDS. So he is beyond sick as an ICU nurse.
And when it goes down the wrong tube like that, that's called aspirating?
Yeah, aspiration, yes.
All right. So had you treated him prior to May 28th?
I'm not sure.
Were you aware that he came in on May 24th? Does that sound right?
Yeah, it sounds right.
So a 4-day hospital stay, man in his 80s, 6 foot, 188 pounds, all those problems you described. And you recall that part of your understanding of his condition was this endoscope to get rid of the sludge and a stent being placed, but that having to be done a second time.
Yeah, there was a complication.
And it's thereafter that he's transferred up there because he has this episode of throwing up blood and aspiration.
Well, kind of, because not stenting that area, not opening up that area, was what was giving him symptoms to have the need for said procedure. So you can go septic from that. So his first initial admission to the ICU, he was for septic shock secondary to the complications of his ERCP or his endoscopic procedure, recovered, had a setback, maybe the infection worsened, the aspiration infection took over, and then he came back to the ICU.
Okay. And when he came back to the ICU, do you recall whether or not he was intubated at that point?
Yeah, he coded, yeah. He would have had most of the things that the first patient we talked about. Usually that is a routine procedure to give people a catheter, an A-line, a central line, which is an IV typically in the neck or groin, and things of that nature. Foley catheter.
All right. So this is how he presents to you on May 28th.
And that's what I get, yeah, that's how he looks, and then of course that's what I get in report.
All right. So you're getting on your shift, you've got the report, what happens next? Do you know his code status?
I don't remember what his code status was.
If the medical record...
Objection.
I'll permit the question, but you went from one question and transitioned to another, so you had a hanging question there. But he answered your tail end of it. Let's move on.
Is there anything I could show you which would refresh your recollection as to his code status?
I'm sure there is, yeah.
All right. Well, let's move on while I'm looking for that. So he is not, though, at this point in your memory, somebody that you're pulling the tube at as you come onto work. Is that right?
I don't understand.
He's not DNRCC.
I don't think so, but I would like to see to be sure. One
Okay.
thing that stood out to me, aside from his vasopressors, the adrenaline that he was getting, was his ventilatory settings. So he was, in a typical ARDS or acute respiratory distress fashion, he was requiring even more support than what usually goes on.
Okay.
So I do anesthesia, right? So most people who get intubated for procedures get, I'm sorry to go on a tangent, but I think it's important.
Well, we need to make sure that what you're testifying to is based on your understanding at the time.
Oh, 100% I would know this, because
Okay.
this is something that I learned after, I said like about a year to a year and a half is when I felt comfortable, so I would have known this.
Okay,
Everybody in this room is breathing 21% oxygen. So out of all the gas and crap that makes up the air, 21% of it is oxygen. When you typically intubate a patient, or I intubate a patient for surgery, or even back then if you had to go on the ventilator for a couple days, you would usually get about 40% oxygen, which is about double, and 5 of pressure, otherwise known as PEEP. It's the amount of pressure in your lungs to keep them inflated. This gentleman was on 100% FiO2, so 5 times the maximum amount of oxygen we can give, and his pressure, which is normally 4 to 5, was 12. So just to keep his lungs inflated and pressurize air through was a chore in and of itself.
but you're able to do that, right?
Yeah,
All right. What about the pain that you're observing as you're treating him?
I'm not sure.
Do you recall him being in a lot of pain when you're treating him? He's on a lot of life support.
Yeah.
Tell us about what you recall, if anything, regarding the amount of pain he's in.
I'm not sure. I know that he took pain medication at home, but I'm not sure if I independently gave him a dose of medication.
Okay. So of all the things that you're treating him for, as he's your patient that night, the
Yeah.
ventilator settings that you've described, the myriad of medical conditions that he has and apparently is declining, pain is not one of those things that you recall having to treat him for.
Not that I recall.
Okay.
There was also, similar to the first patient, he also had an issue where he began to lose perfusion to his limbs. I believe that was also a leg. And much similar to the first, Dr. Husel called to the bedside and a vascular consult was placed. I'm sorry.
All right. Did that vascular consult happen to your memory?
I don't know. I don't think so.
All right.
I would imagine it did not.
Do you recall if this patient was on paralytics or not?
I'm not sure.
All right. Why would you give a patient on a ventilator paralytics?
It depends. The patients can overbreathe a vent. A vent can function in a way where it is going to deliver a set amount of air or oxygen every so often. You specify how often, and it's going to deliver that no matter what. Now you can overbreathe that vent, and you can do what's called fight the vent. So as the vent is pushing air in, you can be trying to exhale, and it can lead to basically issues where the patient is fighting the vent. So you could put somebody on a paralytic medication to take away that ability so you can let the ventilator do its role.
Judge, I'm going to object. Relevance, this patient wasn't given paralytics.
Okay, I'll let it stand as it is. I'll note the objection overruled.
Thank you. May I approach the witness?
You may.
Referring to joint exhibit. What joint exhibit are we on here, please? Mr. Allen is 8. Right? Joint exhibit 8. Joint exhibit 8. Showing the witness a progress note from that date regarding his code status. If you could review
Okay.
that progress note.
Yes, I mean, I don't know, I'm trying to, maybe you can help me, how can I figure out when this,
Okay,
what's the
why don't we
date?
take a recess at this point in time, because it's time for a break. Okay, ladies and gentlemen, remember the admonition, 15 minutes, we'll get started at 15 till. Have a wonderful break. Have a good break, guys. Okay. Sir, you're under oath and you're also on the stand right now. We're going to take 15 minutes. Relax. You can't talk about your testimony. You can answer factual questions for them. But if anybody asks you how you're testifying or why you're testifying a certain way, it's an improper. Okay?
Okay, yeah, I won't say anything.
Go ahead and relax and get off.
That this was forceful, and then later that evening at 11. So I was trying to establish, and he just can't remember, so I was just trying to refresh his memory.
Mr.
I
Zion,
understand
anything
the
for the record?
You want me present to?
But we'll figure it out.
For the record, anything?
Not from the record, Your Honor.
Mr. Baez?
No, sir.
Okay, you were talking into the jury, let's avoid it,
Yes, sir.
okay? And
Yes,
I
sir.
understand, handling the records over here, that you're doing that, but when you get away from the mic, it's tough to pick you up,
Yes, sir.
just to let you know. Okay, we're on break.
Hey. I'm trying to figure out when this note was.
Oh, thank you. This would help me, yes. Okay.
Okay. And then also looking at an order form from the same exhibit that has your name on it. Does that help you recall what his status was when you saw him that night?
Okay. Yes.
Is your memory refreshed now as to his status regarding his, the level of care he and or his family wanted him to receive when you came on shift that night?
Full resuscitation.
Okay. Now, you've gone through some of the issues that he's having. At some point, is there a discussion with the family about changing that full resuscitation status?
There is.
Tell us about, in your mind's eye, looking back on this, how that occurred. Who came to who, what was discussed?
So I was sitting at the nurse's station in the CVICU. It's more of an open nurse's station in comparison to the other side. I was approached by a family member who called me and approached me and voiced their desire to withdraw care.
What happened next?
I told them, I said, I understand. Well, this was also after we presented those things that I discussed earlier about his change with the leg and everything as well. They approached me. I said, okay, I'm understanding what you're saying, but I can't do anything. The doctor has to be at the bedside to hear this. So I called Dr. Husel. Dr. Husel came to the bedside, and then they basically voiced the same desire to stop all treatment.
All right. At this point, is your patient stable?
To me, no.
Is there anything rapidly declining about his condition at this point besides what you've described?
I've described everything that I can think of.
Okay. Do you recall what time of the evening this would have been?
9, maybe, approximately 9 o'clock, a couple hours into the shift.
If the note says this conversation occurred at 11 p.m. In the medical records, would that fit with your memory?
Yeah, that would be more accurate, yeah.
Okay. So once the decision is made by the family to withdraw all care, well, that's
DNRCC.
DNRCC, to withdraw life support care. Let's phrase it that way.
Yes.
What, if anything, is given to you as orders regarding this procedure?
Verbal orders for medications.
Okay. By whom?
Dr. Husel.
And what were the verbal orders for the medications that were given to you?
The numbers are, once again, like the first, they're blurring together, but I know it was 1,000 micrograms of fentanyl was one of them, and there was some dosage of midazolam or Versed.
Is there anything I could show you which would help refresh your recollection as to the amount of medication that was ordered?
Yes.
Before we get into that, so it's 1,000 micrograms of fentanyl. Were you aware at this point of any pain medication that he had received previous to this order of 1,000 micrograms of fentanyl?
Not that I don't remember.
Okay. Had you been actively treating your patient for pain throughout the evening?
I don't believe that I actually dosed him with any pain medication that evening until the withdrawal of care. If
the records were to reflect that he had been receiving a drip of 25 micrograms of fentanyl infusion throughout his stay? Would that help refresh your memory?
Yeah, it would.
And what's the difference, based on your training and experience back then, between a drip and an IV push?
Judge.
For the reasons we've already discussed, overruled.
No, I'm talking about counsel.
Okay. Let's stay back on over. Go ahead and finish your question.
What's the difference between an IVB push and a drip?
It's just the method of administration. One is continuous, the other is, like you said, it's a bolus, it is an upfront, one-time dose.
And if it's gauged at 25 micrograms an hour, how much medicine is that person receiving in 1 hour?
25 micrograms an hour.
Showing you, for purposes of refreshing recollection, the medical administration records with James Allen.
Yeah.
Approach the witness, Your
You
Honor.
may.
Thank you. Oh, okay. Okay. Yes, I'm refreshed.
Okay, all right. So in addition to the 1,000 micrograms of fentanyl IV push, what, if any, benzodiazepine and the amount and manner did Dr. Husel order?
6 milligrams of Versed to be given IV push.
All right. And was this to be given at the same time?
Yes,
And you said these were verbal orders?
yes,
All right. At this point, did you ask for clarification from Dr. Husel?
yes.
And once again, why are you asking for clarification?
Similar to the first gentleman that we described, I wanted to just kind of understand his rationale. I need to hear, just like with any, I mean, it's not really seeking it because of the specific medication. Anytime that there's a new order placed, I want some sort of contextual reason as to why it's being placed. So this was me being like, hey, I know we're doing this for palliative extubation, why are we settling on this dose? Secondary to the fact that this is a different dose than I had given the previous gentleman. So why is there this variation here?
Your training and experience at the time, were you aware of any synergistic effect between between benzodiazepines and opioids when administered at the same time?
Yes, I am aware of the synergistic effect between opioids and benzodiazepines.
Were you aware of that back in 2018?
Yes.
You recall testifying at a previous hearing that you did not have training on that and were not aware of it?
Well, I did not have any formal training on it, but that would have been something that was vaguely covered in one of those daily pharmacology things. To expand a little further, I would have heard the term synergistic effect before, but I had no previous experience from which to pull to say, oh, that's what the synergistic effect is. It had never clinically presented itself to me. I wouldn't even know what it looked like. But I knew that it's this esoteric thing that exists.
Esoteric. Can you define that for us, please?
Oh, I don't know, just like theoretical thing that exists. Maybe that's the wrong word, but to me, that's how I meant it.
Theoretical.
Yeah, like, it had been touched on, but I have no idea what that appears like in practice.
Okay. Thank you. So when you go to the Pyxis, how do you have to get these out?
Entering and pulling them, and since it's verbal, it would have been an override.
And same procedure as before regarding getting the multiple vials and having to put them into a single, well, two, one for the midazolam, one for the fentanyl.
Yeah, I'm not sure how many syringes I used, but it would have been the same process. I would have gone, independently overrode the medications, took them to the room, drew them up, and a syringe administered to the patient.
Okay. And so do you administer these before pulling out the endotracheal tube or after?
I don't remember. My assumption, I don't want to assume, so I don't remember.
Well, do you recall what your practice would have been?
It would have been to give them before.
All right. And why are you giving these doses, why are you giving him fentanyl and midazolam in your mind at this point?
Why are we doing it?
Why are you, in your mind, why are you doing this?
Yeah, much similar to the first gentleman. This guy has a very bad lung injury. He's receiving positive pressure ventilation through an endotracheal tube. His ribs are probably sore from the CPR. He has lost pulses to that lower extremity. His lactic acid level is 20, which for reference, normal is 0 to 1. His is 20. And he has, as before, a Foley catheter and various other medical instruments in his body. And he has been receiving, he would have been on pain medication.
Okay. At that drip of 25 micrograms an hour?
Yeah.
Do you recall charting any of those, did you recall observing, either in your mind or charting, any active symptoms of pain during the course of the evening when you took care of him?
I don't recall.
Okay. If I were to show you the pain score charts, would that help refresh your recollection as to whether you charted any pain medication or pain score for him?
It would, and I guess I just want to be more, you're asking previous to the extubation or just throughout my care for him?
Yeah, previous.
Oh, yeah, I'm not sure. I would need to see that document.
Okay. Do you recall documenting any RAS scores for this gentleman?
Yes.
And do you recall what his RAS score would have been?
I believe I put it either a -3 or a -4. I believe someplace I indicate that he was withdrawing and grimacing.
Okay. But -3 and -4, what would that be regarding his level of consciousness?
He wouldn't be doing, he'd be out of it.
Okay. What about the CAM score? What's that? Do you recall what that is?
I remember it, and I'm confident enough, I believe, to say that that's like a CAM ICU. I think we did that for screening for delirium. I could be wrong, but that's seemingly is what that is to me.
May I approach the witness, Your Honor, for
You may.
purposes of discussion? Showing you the direct flow charting sheets from James Allen's medical records.
Thank you.
Read those, please.
Yeah, thanks. I think that's a double. Is this a repeat? Okay.
Sir, does that help refresh your recollection as to whether or not you charted any pain scores for Mr. Allen previous to his extubation?
Yes,
And did you chart any pain scores previous to his extubation?
I did.
And what were his pain scores?
I charted a 0.
And why did you chart them at 0?
I must not have appreciated any pain on that assessment.
Okay. So after you take out, either before or after you give him the medicine, and it would have been your practice to give it beforehand, you recall, do you recall if the family was in the room with you when this was going on?
I don't.
What happens next? What's the next thing you recall happening?
Much similar to the first gentleman, I would have exited the room, allowed them to stay, allowed them to take whatever time they needed. Was at the nurse's station, and then eventually, once the patient passed, the family alerted me that the patient had passed, or at least I went in once the flatlined, and we kind of came to the consensus that we believed the patient had passed, and therefore I called Dr. Husel to come to the bedside to pronounce.
Okay. And why are you calling Dr. Husel to pronounce if you can see that he's flatlined and no longer alive?
I do believe that there's like a physician obligation to have to pronounce. I can't, that's out of my scope of practice to pronounce death.
All right, so it would have been Dr. Husel, that would have been one of the things he had to have done because you don't have that authority.
Yes.
Okay. When you or others in the ICU document things, do you always do it in real time?
No.
Why not?
Sometimes you're very busy. You can take care of patients that are so busy to where sometimes you need multiple nurses to help take care of a patient. Sometimes you can't even use the bathroom. It's very busy. So my number one priority is to be there for the patient first. And sometimes that leads you to do several interventions. And then when you finally, if you get a chance to sit down, you go back and try to chart what you did to the best of your recollection. I would rather treat the patient than chart instead of charting and leave the patient to go through whatever it is they're going through.
Sure, makes sense. So when is back charting the right term?
Sure.
How would you describe it?
I'm charting to the best of my recollection if I'm not able to do it in real time. So we can use back charting, that would be fine.
Okay, and so would the times of things that happened when you were back charting be exact, or would they be to the best of your recollection?
They would be approximate to my recollection.
All right. Let's talk about December 5th, no. Sorry. Let's talk about October 24th of 2018. James Timmons. Do you remember this patient, sir?
Yes.
All right. So, October 24th of 2018, how long have you now been at the ICU?
Over 2 years, 2.5 maybe, give or take.
Experience-wise, how are you, experience-wise, compared to many of your coworkers at this point?
Objection.
I'll permit it.
While still new, I had been seeking, I believed that I was good, and I think my coworkers thought that, but I mean, I was studying to try to gain entrance into anesthesia school, so I was going a little bit more in depth to sort of how things worked and things of that nature. So as I did that, they started to trust me with sicker patients. So I think I was respected on the unit. I by no means knew everything, but they began to trust me to teach new graduates.
And were you so doing back on October 24th of 2018?
That is correct. I was precepting a new nurse named Emma.
All right. You come on to shift October 24th, 2018. What, if anything, do you recall about James Timmons. What's
Yeah.
presented to you in the huddle?
So I actually recall, I think, a lot. So I walked in, I came in the ICU back entrance. Mr. Timmons was in bed 4 in the ICU. And as I walked into the break room, which is where we got our handoff reports, the crash cart was outside his room. And I jokingly said to my coworker that I was walking in with, wow, that looks like a really rough night. Like, that seems like a labor-intensive night. So after about 5-10 minutes, we did our handoff and we got our assignments. I was told that I was going to be precepting Emma, so we were going to function as one nurse for the care of that patient. So I was assigned Mr. Timmons with Emma, and my first interaction, he was in bed 4, so we stopped. Like, after they told us we had bed 4, we left, because we knew, okay, there's a crash cart outside the room, this is serious. We don't need to hear what's going on with patients that like, we need to get there now. So we went to that patient, and as it turns out, he was being taken care of by a nurse who was also precepting somebody. So the exchange of report was fractured a little bit because it was 2 new nurses trying to kind of get their wheels and get on course. But I'm kind of supervising that. While during report, because it went a little bit longer than usual reports take, and that's okay, he rapidly clinically decompensated. So as we're talking, I watched him on the monitor drop his pressures into, I believe, the 60s. Knowing, coupled just with what I'm seeing a crash cart, yeah, this is not good. So I told Emma, I said, I told the day shift nurse, stop giving report, go get Husel now. So she scurried off, got the doctor. He came to the bedside, he was out on the unit, and we instantly initiated several life-saving issues. And this is really without knowing why we were there yet. So we gave several medications that included sodium bicarbonate. We pushed that through an IV. That is trying to raise his blood pH. And this is all verbally. Dr. Husel's giving this to me verbally, so I am overriding these medications. We give sodium bicarbonate. We do a stat lab level check, and his potassium level is elevated, which places you at risk for cardiac arrest. So we did what's called the potassium cocktail, or the K cocktail, which is a way to artificially lower potassium levels to stop your heart from having a funky rhythm. So we gave calcium gluconate to stabilize the heart. We gave dextrose to raise blood sugar, and then we gave insulin to drive the potassium into the cells to lower that. We then broadened out antibiotics, and what we mean by that, or what I was led to believe that meant, is this was signs and symptoms of like progressively worsening septic shock. So instead of doing like specific antibiotics, just pick the 2 classes of antibiotics that cover everything. So he told us to do that, and then we ordered what's called a stress dose hydrocortisone. And I interpret that at the time to mean that whenever like some degree of stress on the body is good, it helps us mount a fight. So sometimes these patients who are in the ICU need medications, they need the steroids delivered because it helps them mount that ability to fight. It actually enhances the ability of the vasopressors, which he was on, the adrenaline, if you will, to work better. So all that occurred in the first 15 minutes of our shift. And that is fairly atypical, like people decompensate, but that may have been the first or second time that ever happened to me while talking. I don't even know really why we're here, but we need to do something. And Dr. Husel was around the corner getting a report from the residents on the day shift. So me, him, and Emma are basically treating this patient having not even received a full what happened for today. So that's the start of the day.
What happens next?
So he continues to have these episodes throughout the night. His brother is called to the bedside. I'm not sure if I called him or if he was there, but Lynn was there, and we updated him with the situation. You know, he is very unstable to the point where he's swinging one way to the other pretty quickly, minutes really. And I said, we kind of handled that part, but like we're by no means out of the woods. I remember telling him that. And he said, oh, well, it looks like we're going to make it through the night. And I said, no, we will not. I didn't say no, we will not. I said, no, I'm not even thinking about it like that. I'm trying to make it through the next 30 minutes to 1 hour.
I'm going to stop you there.
Yes.
Lynn, when you say Lynn, who are you referring to?
I believe that's the patient's brother.
Okay. What happened next?
So Lynn left, despite us telling him he probably shouldn't. Throughout the night, we were going up on the vasopressors and trying to treat all of his issues secondary to why he presented. I ended up calling Lynn back, and Lynn came, and we updated him with, we had one more episode of sort of that dramatic sort of swinging, like previous. And he began to cry, and he said, take this all away. He wouldn't want to live like this. I don't want any of this SHIT. Take it away. And then much similar to the other two patients that I previously discussed, said, I get what you're saying, but I got to call the doctor. The doctor was called. Husel came to the bedside, and we went from there.
When you say you went from there, what happened next?
So we discussed the goals of care, which was now Lynn's, his brother's willingness to withdraw and make a DNRCC. We told him, and we did have this conversation, that we were going to give him pain medications to let him pass peacefully, naturally, pain-free. We did talk to Lynn about his drug use and his history. We said that he's received a lot of medications throughout the stay. He's coded many times throughout the stay. We didn't discuss the use of fentanyl per se, but we said we were going to have to use like higher doses because of his tolerance. And then we basically told Lynn, and I remember telling Lynn this myself, I said, we're here to do whatever you tell us to do. If you want to keep going, we go. If you don't, we can stop this. It was, and then the decision was made to withdraw care, and then, yeah.
Do you recall what time of the evening this would have been in? Or
It was early morning, so after midnight.
if the records reflect, or is a note signed by Dr. Husel at 3:27 a.m., does that sound right?
Yeah, that sounds appropriate.
All right, so this is on October 24th. So what happens next?
So I think it's important to note here that Emma's great, but Emma also was very limited because she was new. So I was very busy with Mr. Timmons. So there was another nurse that was helping me throughout the night. So really we had like 3 nurses, but Emma was just learning. So it was me and a nurse named Earl. He would pop periodically in throughout the night and help me do all the cares for the patient. Sometimes he would help intervene. He was always on nearby because we knew that at any minute this guy could go the opposite way. So after the discussion with the family stepped out for that one. They went with the palliative care, or not the palliative care, the chaplain, which is like the I don't really know what the chaplain does, other than just kind of help, like a liaison between goals of care. They went with the chaplain to talk, maybe do a prayer, I'm not sure. In that time, Husel was at the bedside. He gave me the verbal orders for the drugs that we administered. I did not pull those drugs. I did seek clarification as to why we were doing that dose. I believe it was either Earl or Emma who pulled those drugs for me. They came back, they handed me the drugs. I had already received confirmation that my clarifying questions were answered by Dr. Husel. I drew up the medications and gave them to the patient. Exited the room, all of us exited the room. Lynn came back into the room. He was spending time with his loved one. Dr. Husel and I were sitting right across from bed 4. There was a nurse's station. We sat right there. About 5 minutes later, the brother opened up the door, pulled the curtain rather, because we had the curtain pulled. And he said, help, help, somebody come quick, he's in pain, somebody do something. From where I got up, I went into the room, Husel followed behind, and what I saw was not great. He was kind of grayish blue, more so gray. He had kind of like foam at his mouth a little bit. He was rocking the paradoxical breathing. The brother was in distress, crying, and it just, yeah, that's what I saw. And from there, I don't know if Earl had heard this noise or the family member calling out. He came back like he did that night most of the time, and Dr. Husel gave another verbal order for more medication.
Do you recall the medication and the amount that he gave a verbal order for?
The second time,
Yes.
it was 10 milligrams of Dilaudid and 10 milligrams of Versed. Once again, I didn't pull those medications. Earl came back with a lot of medications. He had those medications, but he also had Ativan as well. I don't know where that came in. I don't know. He must have talked with the doctor. While this was happening, and I can't remember if it was right before dose number 2 or right after dose number 2, I can't say, but I called the pharmacy. Called and spoke to pharmacist Talon Schroyer, and I told Talon Schroyer, we are doing a palliative extubation on a patient that has a really big opioid tolerance. He said, wait. He pulled up the MAR on his end. I pulled it up on my end. We could see every medication that was out of the Pyxis. And I said, this is what we're doing, this is what we're giving, but I also have this Ativan and additional Versed that I don't think I need because the doctor said give him what he needs, but not too much. So I was calling to say, hey, this is what we're doing, these are the meds that I'm giving. But then also, I was also calling him to say, hey, I also don't want to be responsible for these other medications that the patient doesn't need, and the physician said he didn't need them. I don't want to be, they were handed to me, I don't want these I don't want to be responsible for these, what do I do about that? And like I said, I couldn't remember if that was before or after dose number 2, but I ended up giving the 10 milligrams of Dilaudid and 10 milligrams of Versed. I later then returned the medications that we didn't use.
That would have been the Ativan?
And I think there might have been even Versed there as well. But I know that there was, at least Ativan was returned. There was a weird discrepancy in the Pyxis where it appeared like we gave him more Versed than what I actually administered. So the total dose that the patient received was 1,000 micrograms of fentanyl, 10 milligrams of Versed, 10 milligrams of Dilaudid, and 10 milligrams of Versed. All in the, in that time that I detailed, and then we returned whatever medications were left over because we didn't want to give them too much.
So when you return, does that sometimes show up on the Pyxis log as wasted?
I think so. I say return. It very well could have been a waste. I know that I went with the nurse who pulled them because that was who they were, the fingerprint was on who got them out, and we did something to take account that they're not being given to the patient and being disposed of properly. Either returned or wasted, I don't remember. I just say return because that's what I think.
All right. Let's talk about the call to pharmacy.
Yeah,
You recall on your first palliative extubation calling Greg White.
I did.
You recall seeing Greg White on the floor thereafter.
Yes.
You recall him at least going to the room with Dr. Husel.
I just remember him being on the floor.
Okay. You're not aware whether or not he actually had a conversation with Dr.
No, I
Husel.
wasn't. If he did, I wasn't a part of it.
You did not testify about calling pharmacy on the second palliative extubation.
Correct.
Now, this third extubation, you did call pharmacy because of this Ativan, that Earl Huron, is that who we're talking about?
Well, it wasn't just because of the Ativan, but that was a part of it, yes.
All right, and talking to Talon.
I did.
And so this would have been the first time you have talked to Talon about these drugs, these doses, and what the particular procedure is being used for?
Yeah, to my knowledge, I had never spoken with Talon in regards to a palliative extubation before. I had talked to him numerous times because he was a night shift pharmacist, but in the context of withdrawing on a patient, that was the first time I called Talon, and I told him that we were doing it for a palliative extubation.
All right. Was there another reason calling Talon besides the waste? Or the extra drugs, I'm sorry, besides the extra drug?
Yeah, just like, I mean, I think I was just kind of like, hey, we're giving these medications because this guy's a chronic opioid user. To me, it's just, that's a lot of medications to be out of the Pyxis at once. So I wanted him to know this is what they're being used for, this is why they're being used. It's a guy who has a very big tolerance to medications because he was admitted, and it turns out that there was something with his drug use. And then I also didn't want to be responsible for medications that were just freely floating around the unit. So it was kind of twofold.
Was it a common practice in the ICU at night to have one nurse pull medication and then hand it off to another nurse to administer that medication?
I wouldn't say that it was common, but I can't say that it's uncommon. You know, like in a code situation, nurses would hand medications across the patient as you're doing CPR and say, that's epi, push it. You know, there are nurses who would grab bags out of the Pyxis for you. If you're in a room, you're like, hey, override this or not override, I'm sorry. That's not the word I wanted to use. Grab this medication for me, please, just because I'm in the room and you're at the Pyxis. So maybe that's not the best practice per se, but that occurred on the unit.
Okay. And once, going back to whether this is an emergent situation or not in your mind, is this palliative extubation of James Timmons an emergent situation requiring, like, you described a code with the epi thing, right? That's
Yeah.
emergency, that someone's flatlined, right?
That would be what the code is, yes.
Is, in your mind, James Timmons the same type of emergency?
In my mind, I do. I do believe that to be an emergency. I see rapid clinical decline. I see a night full of swinging blood pressures, vasopressor use. The family is distraught, and now he's asking for more medications. Like, to me, that is, I would say that's an emergency for me.
Yeah, well, I'm talking about initially, because didn't Earl pull the 1,000 and the 10 initially too?
Well, I don't know why he pulled those. I mean, I know he did pull them, but I wasn't a part. I can say that if Earl didn't do it, I probably would have overrode those medications too. But I don't know if Earl thought it was an emergency or not. I have no idea what he was thinking.
Did you ask Earl to pull those medications though for you?
I don't know. No, I don't believe so. I'm not sure.
Was Earl part of the care of James Timmons that night?
He wasn't assigned to him, but Earl was very helpful in his care because he had experience as a nurse and was my neighbor. He was taking care of patients next to Mr. Timmons. So it was very common in practice for nurses, even if you weren't assigned to care for that patient, you would go in and help because they're people that need help.
Sure. Well, since this has been brought up as an issue, a possible issue, were you stealing those drugs?
No,
Were you aware of anyone stealing those drugs?
no.
These practices that you describe, I'm sorry, I've been told to be quieter. So, these practices that you've described, and Judge, I look this way just to project that way. If I can just kind of do it this way.
That's fine, just.
Okay. These practices that you've described of one nurse grabbing them, giving them to you to administer, to your knowledge, did that involve anybody stealing drugs? To your knowledge?
No, everything that was ordered, I received in their entirety, and I drew them up and pushed them.
Okay.
Nothing was unaccounted for. If the order was 1,000 of fentanyl, there was 1,000 of fentanyl there.
All right. And if the records reflect that you gave Mr. Timmons 1,000 of fentanyl, that's actually what occurred?
Yeah, I gave it to him,
All right.
intravenously.
And then you also gave him at 3 o'clock the midazolam too, the 10 milligrams of midazolam.
I did.
All right. So how soon after giving those drugs did Lynn come out and say he's still in pain or whatever he's saying to you, he needs more pain medication? How soon after that initial dose do you recall giving him that second dose?
Roughly approximately 5 minutes, 5 to 7 minutes maybe.
Your knowledge in 2018, how quickly does fentanyl and midazolam work in a person's body?
I think you need a little bit more sustained.
Were you aware of how quickly midazolam and fentanyl worked in a person's body in 2018?
Specifically, no.
Okay. So you hear Dr. Husel give another verbal order at 3:05. Does that sound right? You said about approximately 5 minutes later?
Yeah, roughly.
Hydromorphine, that's also Dilaudid. That's just the name brand.
That is correct.
10 milligrams of that,
Yes,
and that was IV push.
it was.
And then another 10 milligrams of midazolam,
Correct.
and that was also IV push.
Yes.
And that was pulled by Earl because it was kind of urgent at that point.
I think it was Earl or Emma, yeah. I think Earl, I'm comfortable saying Earl.
All right. And did you prepare those doses, or did Earl prepare those doses, or did Emma prepare those doses?
I don't know about the second one.
All right.
I'm the one who gave it.
And you have a memory of giving those doses IVB push at 3:05, approximately?
Approximately, I do. I was the one who administered them.
What happened next?
The patient's family member thanked us for more meds, and we went back to our standard outside the room. You know, I kind of monitored the situation for a second. I suctioned his mouth because there was the stuff hanging out of it. He looked, the paradoxical breathing was maybe a little bit better, but I left the room, you know. To me, it's more about the family being in the room. You know, I want to stop being like, oh, let me do this assessment, let me do this. Like, the vasopressors are off. Like, those are out of your system and very quickly. Like, he needs to be here, and I need to step back here a little bit. It's less about me and more about his last moments being with his family member.
Okay. Prior to his extubation, do you recall whether or not you charted any active pain in Mr. Timmons?
I let Emma do most of that charting, and since we were one nurse, like one entity, I don't remember, I can't be specific, but if it was, it would likely be under Emma, aside from the dose that I gave palliatively when I recorded a pain score.
Okay. Is there anything I could show you regarding whether or not pain scores were charted during this time?
Yes, please.
Okay. Showing you from Mr. Timmons' medical records, the direct charting flow sheet. I was just going to show him this. May I approach the witness, Your Honor?
Amen.
Thank you.
Does that help refresh your recollection as to whether any pain chart, in the pain chart, if any pain scores were recorded?
Yes, it helps refresh.
What were the pain scores that were charted during your care of Mr. Timmons?
Emma, and which I guess means me, charted zeros.
Okay. And why is Emma charting that as your preceptor? Are you instructing her, or is she doing this on her own?
I'm letting her do her own assessments. Ultimately, that's her charting. But I'm making sure more so that she doesn't record something off the wall like a -2. Like, she had her own process of how she comes to that number. As long as she has a why as to how she got to that number, I'm okay with that. I'm signing off to make sure that she's keeping the integrity of the process, more so than, I'm not telling her, that's a 0 because of this. Like, The way that I would educate is I would allow her to come to her own conclusions, and as long as she had a rationale as to why that is her conclusion, I'm okay with that.
Do you recall that being an issue? Do you recall seeing Mr. Timmons in any pain, grimacing, the things you've described, which would indicate pain for somebody on a ventilator, that would indicate Emma's not correct there in the zero pain score?
I do believe he's on a fentanyl drip at the time, so what I can say to that is maybe he didn't need a PRN breakthrough while on our shift, but he was already requiring something to control pain. So I don't know if that answers your question.
Well, the question is did you observe Mr. Timmons to be in any active pain while you were taking care of him?
I'm not sure I can recall that.
Did you ask for clarification from Dr. Husel in front of Emma when these doses were ordered initially?
Yeah, both times.
And what was the purpose of asking for clarification from Dr. Husel? This is now the third time, and the same doses approximately as the previous two.
Yeah, sorry. Two reasons. The first is less important, but it's a reason, is Emma needs to know that she can approach doctors. She needs to see that is very scary sometimes for people to talk to a doctor and say, hey, what do you mean by this? Especially being new. Fortunately, he was approachable, so I wanted her, she was going to be working, I want her to see that, one, it's an expectation that you clarify. Two, it's okay to question doctors even when it's scary. Three, the doctor that you're going to be working with is approachable and respectful when you come with questions. And then four, I'm still seeking that same clarification. At the end of the day, I'm still responsible for that patient. So it's kind of fourfold. It's an education thing for Emma, but it's also like, hey, this is still Mr. Timmons here. This isn't, as much as Emma's education is important, Mr. Timmons is the priority here. So I need to make sure that we're on the same wavelength as to why we're administering these dosages.
Okay. So that was October of 2018, October 24th, so it's the end of that month, getting to the end of that month. In December of 2018, so about 5 weeks later, give or take, do you recall being summoned to HR?
Yes.
Why were you summoned and what happened then?
So I'm not sure I ever actually worked a shift after that. I think I went on like a vacation or something, and I was placed on administrative leave. I was summoned to HR for what they told me was a fact-finding endeavor. That was their words. They asked me questions about ICU practice, about overriding medications, and they asked me about, well, I think that's really what I remember.
Okay. Were you thereafter taken to another room and asked to speak to the police?
No, so I actually was summoned to a meeting from HR. I think I met with Katie Barga. I think that was her name. She kind of vaguely alluded to what ended up, what we all know now, but it was very like, oh, this is just us, finding some facts, nothing's going to happen, stuff like that. Then, give or take sometime later, I was called and said, hey, come to Mount, because I'm still on administrative leave, so that's my job. They say, come to Mount Carmel West. It's not the hospital, but there's an attached building, which is like where the big wigs sort of have their offices. Come there, we're going to do a little bit more questioning. I went there, so it's the second time I went back, and I was told then, spur of the moment, that I'm going to meet with Columbus homicide detectives.
Did you thereafter meet with them?
Oh, yeah, I did.
And made a statement?
Oh, yeah.
Okay. And what's the next thing that happened regarding, you were on leave from what date, do you recall?
I don't recall. I know that what ended up happening with me,
Okay, I'll permit the answer for now. Go
Just at
ahead.
Mount Carmel is all I'm talking about.
what happened next,
I'm talking about when were you placed on administrative leave, if you recall, from Mount Carmel? So this is before you met with the police, you're already on leave?
I think, it's vague to me because I ended up leaving Mount Carmel. I resigned on January, I believe, 19th or mid-January, I resigned from that position.
In 2019,
2019, yes,
while you were on leave?
while I was on leave.
Okay, very good.
They had,
Okay,
I'm sorry, yes, I'm done, yeah.
we do by question and answer.
Yes, sir, I'm sorry.
Just a few more questions about James Timmons.
Okay.
You had mentioned that he had been on a drip, you had knowledge that he had been on a drip of fentanyl that evening or previous.
Yes,
Do you recall the amount of drip he was receiving per hour?
I do not.
Is there anything I could show you which would refresh your recollection as to the amount of drip he was receiving?
Yes,
It's right there, it's the 25 micrograms.
okay, thank you.
Does that refresh your recollection as to his previous drip?
Yes,
What was he receiving?
175 micrograms per hour.
Do you know what that white foam in his mouth you described after you gave him the 1,000 microgram push was from?
No, I have no idea. I know it's secretions. I don't know why it's caused.
Had you seen that before in any other patients?
Not like that. That was significant. Like it was, almost looked like an Alka-Seltzer tablet was in his mouth.
Had you ever treated anybody that was actively overdosing on fentanyl?
Objection, Judge.
Well, I'll permit it.
No,
Thank you. No further questions.
Cross?
What? Oh, I'm sorry. Just, yeah, I gave you one
That's
yes
all right,
last
we
week.
got it.
Thank you, nothing further.
Cross?
Get all my stuff over here.
Please report. Good morning, ladies and gentlemen. Good morning. Good morning, sir.
good morning.
I want to start from the beginning of your direct. You were asked if most of what you learned your first, I guess, most of what you learned was from Dr. Husel. Do you recall that?
I recall them questioning me that.
Okay. But you, in fact, had learned quite a bit from your preceptors, right?
Yes, I learned from other nurses, respiratory therapists, and I did my own independent. I said I bought books. I was reading at home. So he taught me a lot, but it was not, I learned from everybody.
In fact, you learned from your preceptors and other more experienced nurses that 1,000 micrograms of fentanyl was an appropriate dose during a palliative withdrawal. Isn't that correct?
I was told that it's patient specific and that would not be, so like that is very well possible.
Okay. Do you recall in another proceeding giving a deposition in this case?
Yes.
Okay. And do you recall that date was February 26th of 2020?
Yes.
Do you recall when discussing Mr. Millett that you testified under oath that it was an appropriate dose?
Yes.
And then later on you were asked, you said you were trained that it was an appropriate order. Who trained you that this was an appropriate order? And then you answered, my preceptors. I mean, just the way that a nurse learns. Aside from that, you know, you gather, maybe in school, you learn primarily how to function in your role. It's almost like a residency.
Yes, that,
Okay, you answered the question.
yeah.
Okay. So you would agree that your experience, on-the-job experience, is quite a teacher.
I would say that is probably the best teacher.
Okay, so if you had certain experiences, you would utilize that in perhaps your next patient that you run into a similar situation, right?
Yeah, I try to store those experiences that leave a lasting impact, and I tap into those for my future treatment. It helps shape my practice.
Okay. Now, I want to talk a little bit about Mr. Milletti. Are you familiar, you testified under direct examination about acidosis. Do you recall that testimony?
Yes.
And you utilized it as a gauge as one of the factors as to why you took into consideration the 1,000 micrograms as one of the reasons why it was appropriate. Do you recall that testimony?
One of the reasons, correct.
Okay. And are you familiar with the pH range that's compatible with life?
Yeah, and I'm familiar, I would have been familiar with that in my practice, back then as well.
Okay. And you know that it ranges, what's the normal range?
So the normal range, textbook range, is 7.35 to 7.45. For simplicity, most people just say 7.4. That is the scale, yeah.
I get into a little bit more.
Okay.
And I want to show you a document in reference to the scale and see if it looks familiar to you.
Okay.
You may. Did you show the other side?
Yes, I did. Does that fairly and accurately describe what you understood at the time that you were working on with these patients, what the pH scale was?
Yes.
Okay. May I publish, Your Honor?
Any objection?
Object, Your Honor, as to its relevancy with this witness.
It was
He's
brought
not
up.
an expert. This is something he didn't prepare. This is nothing he has experience with. He's not here to testify regarding any of that.
counsel brought out during direct examination his consideration of the pH levels. And this witness is familiar with the pH scale, and this is what he utilized to analyze whether this was
That
the
isn't what he
appropriate
said. He
dose.
didn't utilize that document. That was the first time he saw it.
But he utilized the scale. This is all this is the scale. It's not some document.
Sustained.
Sir, on the pH scale, you said that 7.4 is right where you want to keep your patient, correct?
Yes,
And you're familiar that Danny Millette was at 6.96, correct?
I am familiar with that value.
Okay, and 6.96, or actually, at what point on that scale is it not compatible with life?
For me, in my practice, begins to tread on fatal at or below 7.2. So if I see anything less than 7, that is significant. That is, we need to either change something or everybody needs to get on board with what the goals of care are. That's not compatible with life. Under 7 is, you won't live.
And could you explain to the ladies and gentlemen of the jury what pKa levels are and how that relates to, based on your training and experience, the pKa levels and how that relates to the administration of fentanyl?
Objection, Your Honor.
Sustained.
All right, let me ask you this. Are the pKa levels something you would have considered when making the determination whether a dose is appropriate?
Objection, Your Honor.
Sustained.
When you questioned, or when you clarified, I should say, the order with Dr. Husel, and he gave his explanations, was the pKa level something you considered?
Objection, Your Honor.
I'll permit that one.
At the time it was mentioned, I did not understand what it meant per se, but it was definitely something that was mentioned.
Okay. Now, you mentioned that Mr. Millette was a pretty sick man.
Yes,
And at the time of his palliative extubation, he was actively dying?
I believe so.
Okay. And when someone is actively dying on full life support, is that an emergent situation?
Actively dying, yes.
Okay. So, when did the family approach you in reference to doing the palliative withdrawal?
What I can say is they were updated with the status, but for Mr. Millette and all of these patients, the decision to switch code status to DNRCC was the family-driven initiative. It was not, every time we would conclude with, we will do whatever it is you want us to do. We will keep going, but if you don't, just let us know. We are there for you.
I forgot to mention this. There was a lot of testimony in your direct about your inexperience and your training. This palliative withdrawal actually occurred a year after you had started, correct?
Roughly, yes.
And this is a year of working in the ICU, correct?
Yes.
A year of working with preceptors or other experienced nurses?
Yes.
And this is having to see several other, or I should say many other palliative withdrawals, correct?
I've seen other palliative withdrawals, yes.
Prior to ever having to do or be in charge of Danny Millette's palliative withdrawal?
Yes.
Okay. So you weren't exactly a rookie, so to speak? For lack of a better word.
I don't know what the value is to where you become a veteran, but I had seen some before. This was not my first palliative withdrawal.
Okay. Now, you mentioned that Dr. Husel would sometimes pull you aside and train you, as well as other nurses?
Not just nurses, techs, even people that are just like stocking rooms that want to go to school, respiratory therapists, everybody who worked on that unit, he was an open resource for.
And this is a teaching hospital, is it not?
Yes.
So it's not unusual to teach other healthcare professionals while on the job, correct?
I agree.
And in your experience, Dr. Husel was always approachable?
Oh, 100%. I mean, he was, I have been at many different hospitals previous to that and since that, and there has not been another physician that I have encountered that didn't make himself available as he did, didn't freely educate as he did. Sometimes it's like pulling teeth to get them to give you something. And I've seen him go what I believe is above the duties that some of the physicians I've worked with usually do.
Now, you have, as your experience grew in Mount Carmel, you then became part of what is called a code team, did you not?
Yes, I was part of the Code Blue team.
Tell the ladies and gentlemen of the jury what that is exactly.
So since ICU nurses are required to have, or at least at Mount Carmel, they were required to have advanced training in life support measures and saving people in emergencies. I had that, and I have that. 2 nurses from the ICU would be placed on what's called a Code Blue team, as well as the attending physician in the ICU, which some nights would be Dr. Husel. So what that means is anywhere, any place in the hospital, if there was a code where a patient died, those 2 people, the 2 nurses and the doctor, would be responsible for going to that location and trying to bring them back.
And is this something that an ICU doctor has to do?
I don't know. I know that,
Okay, you answered the
yes,
question?
I don't know.
But you say that Dr. Husel, I guess, during work would go above and beyond.
Yes.
And as a member of the code team, did you have the opportunity to do codes with Dr. Husel?
I've done a lot, yes.
How much is a lot? Give us a little more context. More than 50, less than 50?
More than 50, I think a good number is 70, 75.
So about 75 times you witnessed Dr. Husel saving lives.
Well, it's, on the code team, yes, but there's more than just that. You know, I can recall a moment where there was something paged overhead. It was a level 1 trauma. So,
At this point, I'm going to object as to relevancy.
Sustained. It's time for lunch anyway. Ladies and gentlemen, if we start back up at 1:15, will that give you guys enough time for lunch? Well, which would you prefer? Not that it's your decision, but it's mine, but 1:15, this door safe? Okay. Remember the admonition, we'll get started accordingly.
All right.
Have a great lunch, guys. Sir, you may be excused until I come back at 1:15. Remember my prior ammunition. Mr. Byers, you're on the floor. Anything for the record?
Nothing from the defense.
Mr. Zion?
No, Your Honor, thank you.
both of you two have taken shots at me about what I told you the other day. Okay? Really?